very grateful to say that we have Associate Professor Sandra Peake here. She is a Chief Investigator on this centre and is a Senior Intensive Care Clinician at the Department of Intensive Care at Queen Elizabeth Hospital. She's also an Associate Professor in the School of Medicine at the University of Adelaide. She's Chair of the Intensive Care Foundation Scientific Committee, Chair of the Research Committee for the Acute Care Medicine discipline at the University of Adelaide, as well as a member of the Australian New Zealand Intensive Care Society Trials Group Executive Committee. Now, Sandy's going to be talking to us today on using collaborations and networks to perform more meaningful research.
Thanks, Jason, for inviting me to speak today, and thanks for the topic. I always like speaking on nebulous topics rather than pure science, so thank you. Collaborations. What do we really mean by collaboration? So if you look up the Oxford Dictionary, you'll get a definition of united labour, cooperation, especially in literacy, artistic or scientific work. The Webster Dictionary gives a different definition, but essentially what we mean by collaboration is a group of people who have a diversity of skills or an organisation that works together to achieve a common goal. And they do this in a cooperative fashion with meaningful collaboration from all of the members of the group. And the upshot being is that you will have enhanced benefits as opposed to individuals working in their own silos. Over the last 20 years or so, in science in general, but also in the medical research arena, there has been an increase in the number of collaborations and teamworks. And we can see this if we look at the number of publications in high-level journals that have group authorship. So in this panel on the left, we see the number of group authorship is actually increasing, and so whereas in the 1980s there was a very limited number of group authorship has increased to over 17% now. And this is for high-level journals like the New England Journal of Medicine and Annals of Internal Medicine and JAMA. And in addition to that, the number of authors within a group authorship has actually increased from 4.5 up to 6.9. So I think this reflects a general belief amongst certainly the medical community that we can achieve more as collaborations, and in part I think is reflected by the increase in complexity of medicine and research that's being undertaken. So what types of collaboration are there? Well, most of us collaborate every day in our working life as a researcher. We might just simply be collaborating with the people who are sitting at the desk next to us, or someone across the road working within the same discipline, or perhaps even a different discipline. But then at the other end of the spectrum, there are these integrated research teams, which is what we believe the reduced CRE is. And essentially that's a group of individuals who are working together on a problem where each of the members of that team bring different expertise. There's regular meetings to talk about and discuss the overall goals, what individual members' objectives are, the sharing of data and how data is analysed, and what the next steps are for the collaboration. In general, in these high-level collaborative teams, there will be one person who takes the lead, but then there are other members of the team who take ownership of the collaboration and have important roles as leaders also. So what are the advantages of a collaboration rather than individuals working in their own silo? The advantage is that people who come together with varying strengths all work together, and by doing that they're able to accomplish something that each of them could not accomplish on their own. You as a group of individuals bring a diversity in brainstorming, problem solving and ideas, and this leads to greater creativity and innovation. So the whole is greater than the sum of its parts. And for anyone that's played a team sport, we know that there's no I in team. Another advantage of collaboration is there's probably increased likelihood of funding success. There's a greater research capacity. When one puts a grant in, you have the collective track record of multiple investigators, and there's also greater intellectual input into the grant itself in terms of the research proposal and also just simply how the grant is written. And all of those things increase the likelihood of funding success. As important, or perhaps even more important, is that funding agencies believe in the power of collaboration. The National Health and Medical Research Council are currently undergoing an evaluation of their funding process, and they've come up with 3 different models for which they're at the moment doing a travelling roadshow around Australia to get feedback from researchers from. But 2 of the 3 models that they propose strongly emphasise the importance of collaboration. So in Model 1, for example, there is a large proportion of this funding pool that goes to teams in order to conduct collaborative research programs. And if you look at the actual second model, you actually get a bonus for collaborative research. So forming collaboratives under the proposed new models, whichever model is taken up by the NHMRC, will certainly promote this or foster this idea of collaboration. Another advantage of collaboration is that there's probably a greater impact of your research findings. If you look at the New England Journal of Medicine, for example, 25% of papers published in the New England Journal of Medicine come from group authorship. It's also recognised that international co-authored papers are more highly cited versus single nation papers, and co-authored papers are more highly cited than single author papers. So in this graph here, we see that as the number of co-authors increases, so too does the number of citations of your paper. There's a whole host of other advantages of collaboration. It's certainly time efficient. If you've got a number of people all working on different areas of a project, all with a common goal, you're much more likely to get a result sooner, and that's better for translation into clinical practice because you'll get the results sooner. It's also cost effective. You can share resources, infrastructure, you build capacity. It also has thinking on a much more global scale. It has a societal value where developed countries can participate in collaborations with developing countries. There's also, from a personal perspective, there are great benefits. It's a great way to learn because you're exposed to a whole lot of other experts. It's a very efficient way of learning. And there's also that social aspect of working in a team and sharing your successes. So how do we assess whether collaboration is successful? Well, there are many ways of assessing it, most of which are probably intangible. There are more tangible ones, such as biometrics, like the number of publications, where they were published. Have those research findings led to an uptake or change in clinical practice? Whether you've got ongoing funding success and completed higher degree students. But there are also those less tangible ones, like have you, for example, developed a succession plan where the people who perhaps were successful in setting up the collaboration have then moved on to other pastures, but there are people left behind that have been brought through the system who are able to take over. And there's also the research capacity and infrastructure and so on. And these are obviously a lot less tangible than numbers of publication. So one example of a very successful collaboration is the ANZACS Clinical Trials Group, which Jason mentioned I'm actually the vice chair of. And if you actually went through all of those metrics for assessing a successful collaboration, the ANZACS CTG in fact ticks all of those boxes. For those of you who don't know, the CTG was started in 1984 simply by a group of interested clinicians, and the aim being to promote collaborative clinical research within the ICU arena. And it was when it was first started, no one had a clue what they were doing. And there was a small study published in the Lancet in 2000. But by 2004, the first large-scale clinical trial of 6,697 patients was published in the New England Journal of Medicine. And that trial, when it was published, was said to be a milestone for the discipline of critical care medicine and a landmark trial. Since then, the CTG have randomised over 43,000 patients into clinical trials and over 25,000 patients into observational studies. Over $80 million in NHMRC funding has been received. There's been a large number of peer-reviewed publications and 10 in the New England Journal of Medicine. And so when I was preparing the talk, I reflected on what has made the CTG successful and what are the lessons we in the CRE can learn from that. And essentially, I think there are a number of factors which have made the CTG successful. The first of these is that we have a group of committed clinicians who share the same vision and goals. And we began and still continue to have visionary leaders who have drive and dedication, but also have great leadership skills. We've been able to bring together a diversity of specialised experts in various fields within critical care, and we've been able to imbue a sense of stakeholder ownership amongst all of the members of the ICU community. We have individual ICUs are members of the CTG, not individuals per se, which means that if you're working in a CTG unit, you're automatically part of that CTG family. We also have tried to maintain equality by having a publication policy which indicates a group authorship policy, or where group authorship policy doesn't happen, it is in alphabetical order. There's regular and frequent meetings at which scientific debate is encouraged around various research projects, and we've set up communication networks. So we know that REDUCE is going to be successful, but why is that so? Well, we have brought together a multidisciplinary team with a diversity of skills, and each of the members of the team are internationally recognised leaders in their field, including infectious diseases, intensive care, biostatistics, pharmacometrics, and so on. We've also proven to have, individually, have successful local and international collaborations. And as we can see from this this little insert here, this is the network of publications within the group. So we already have proven successful collaborations, both in terms of publications and funding success. We do have a group of strong, motivated, visionary leaders, and regular communication and meetings will be planned. And I think importantly from my own clinical perspective, this is filling an important clinical void. 70% of patients in ICU need antibiotics, and every day as a clinician I'm faced with, is this the right dose for that antibiotic? And also, importantly, we will have mechanisms for translating our findings into clinical practice. So the Olympics are starting in a week's time, so I just want to finish with a slide of the Australian Olympic track cycling team pursuit team. And this is an Instagram quote from Annette Edmondson, who won a bronze medal at the previous Olympics. And currently this group hold the world record in team pursuit. And as Nettie said, together we are stronger, fitter and faster. I wouldn't be able to do it without these girls. And I think that embodies what the REDUCE CRE is. But we'll add in the boys as well. Thank you.